My name's Timothy Tardibono. I'm the Washington, D.C. Director for Connect. For those of you who don't know, just this last year in April, we opened the D.C. office for Connect to try to bring the voice of the innovation community to Washington, D.C., both to Congress and the administration. We really felt that there is a lack of understanding in the administration and Congress as to what innovation is, what an innovation ecosystem looks like, and so we are there full-time trying to bring the voice of San Diego's innovation community to Washington, D.C., and I'm glad to be able to be here and not in the 20-degree weather that is in Washington, D.C. right now. Thank you. Real quick, I just wanted to give you all a little snapshot of how we developed this topic, and we're glad to see such great response. When we were working with Buchanan Ingersoll on this topic, we started talking about healthcare reform, how important that was, and all the wireless health innovation that was going on, especially here in San Diego, and we really feel like San Diego is one of the pioneer regions in wireless health innovation. But we felt like so much of the time there is focus on innovation, but not on what's the next step. What happens as the FDA and the FCC start delving into regulating wireless health innovation? And then the next step after that is, what about reimbursement? How will there be reimbursement plans that are developed? And related to that, will doctors, medical practitioners embrace and adopt those technologies? So that's the backdrop of how we developed this. We realized that during the healthcare reform debate, and we expect during this next year, there's been a lot of talk of how to bend the cost curve down, but not really looking at how can wireless health innovation help us do that, and secondly, how can we incentivize doctors and medical professionals to embrace these new technologies. So we'll get on with the program. I want to introduce Ed Alera, who is going to be our first presenter. He is a shareholder at Buchanan Ingersoll in their D.C. office, and I'm sure he is glad to be here instead of D.C. And he has a lot of background that you can read it in your program in FDA, devices, other approval mechanisms and processes, and we have been greatly helped by his assistance as we've set up the D.C. office and worked on FDA approval processes. If you want more details, you can look in your program, but I'll not bring Ed up, and thank you very much.
Hopefully I can get this to work. I think we're on. Okay. Good morning. I'm delighted to be here. I spend a fair, in addition to working from D.C., I also spend a fair amount of time working from our San Diego office, and I definitely picked the right week to be here. And this is not my car. I wish it were. I knew people who had them. Avoiding the FDA time warp. And why would an FDA lawyer say to avoid FDA? And the answer is, you really have to look at the practical aspects of getting your product to market. And when you have a problem with FDA, you don't have a problem with FDA. You have a Washington problem. And I think what I want to talk about today is, how do we help you get through the practical aspects of getting your product marketed and paid for while FDA sorts things out? Now, the general framework is the Federal Food, Drug, and Cosmetic Act of 1938, which we couldn't even find a slide for one of those Underwood typewriters, but that was the technology, and there was no they added pre-approval of drugs, but there was no pre-approval for medical devices. Pre-approval of medical devices came in 1976, and we had dial phones and Selectrics, which were, as you probably don't remember, was like miraculous. You could actually type, and we had technological improvement, but we had pre-approval of medical devices. We had 510Ks. You're substantially equivalent to something on the market in 1976 or before. Pre-market approvals, where you had to show you're safe and effective. We ultimately had CLIA exempt, where you didn't have to have anything. You could self-show you're covered, and device classification. And since most of the work is in pharmaceuticals and FDA healthcare work, this was considered FDA light. It was really engineering versus clinical. And it was primarily engineering. Most of the medical device activity is really engineering. It had this incredibly lengthy definition of medical device, which you can read at your leisure. It's not very interesting, but it just covers everything. So if FDA wants to go after you, they will claim jurisdiction. They have a good case that they're an adjunct or something like that. The next move, and I think important for us, is 2007 when they added user fees, and user fees have to be reauthorized in 2012. So now we have, in the intervening years, we've had this breakdown and pigeonholing, this myopic view of everything gets smaller and smaller. We've had medical devices become more refined and more refined. We have companies and law firms focusing on 510Ks and PMAs, different groups, pre-approval, post-approval. And as we've had this technology develop, we've become pigeonholed. We've had increased costs. And then we had this catastrophic boom in 2008. So the environment today is totally different than existed 5 years ago, 7 years ago, 10 years ago. We have the government's broke, the states are broke, we have congressional oversight that's vitriolic in every way, shape, or form, and we have this battle of, it's like East Coast and West Coast rap. You have at FDA the physicians versus the engineers. So we have this dilemma where they want more and more data to support devices, which is going to slow the process down, and you have so-called conscientious objectors who rush to Congress and say it's all pro-industry and FDA really isn't for innovation, therefore money for the industry. So we have quite a poisonous environment. Now, for overall healthcare, you have to remember that FDA is part of the Department of Health and Human Services. The Obama administration, I think the Bush administration, is part of the Medicare Reform Act in 2003, added money for information technology that really senior healthcare officials believe is the door opener to healthcare reform and cost savings. So you have CMS, the Center for Medicare and Medicaid Services. They see wireless technology as the answer. The Office of National Coordinator for Healthcare Technology, they're really good people, they're really out there, and they're overseeing everyone, but they really can't control anyone. They meet with FDA, and FDA says it's not the answer, it's the problem. They're worried about what happens. FDA only sees problems. I was looking for a slide for Chicken Little, but I couldn't find one. But I think they're going to rain on the parade. So FDA, their fear is problems. So while FDA is not monolithic, you will deal with various sectors of FDA in the review sections, in compliance. As you move up the line, they'll tell you one thing. When you really get down in the nuts and bolts of it, they'll tell you another. So they're not monolithic, but they're monotheistic. They don't want to get caught making a mistake. When it's new technology, they don't know. They're not going to be the one, like they used to say, they don't want to be on the poster of Michael Jordan dunking. They don't want to be the person whose picture shows up on the front page of the newspaper testifying before Congress because something went wrong with wireless technology. So they're cautious. That is just the nature of the beast. FDA has looked at this and they've said software is a medical device. They generally haven't enforced it, but they're not going to let go. They're not saying they don't have jurisdiction. And they're nervous because they've seen adverse events and it's caused FDA's concern.